Peritonitis. Peritonitis is inflammation of the peritoneum, the serous membrane lining of abdominal cavity and covering of the viscera. Usually, it is a result of bacterial infection. The organisms come from disease of the GI tract or in women from the internal reproductive organs. Peritonitis can also result from external sources such as injury or trauma. Example, gunshot wound, stab wound, or an inflammation that extends from an organ outside the peritoneal area, such as kidney. The most common bacteria implicated are Escherichia coli, Klebsiella, Proteus, and Pseudomonas. Inflammation and paralytic ileus are the direct effects of infection. Other common causes of peritonitis are appendicitis, perforated ulcer, diverticulitis, and bowel perforation. Peritonitis may also be associated with abdominal surgical procedures and peritoneal dialysis. Pathophysiology. Peritonitis is caused by leakage of contents from abdominal organs into the abdominal cavity, usually as a result of inflammation, infection, ischemia, trauma, or tumor perforation. Bacterial proliferation occurs. Edema of the tissue results and exudation of fluid develops in a short time. Fluid in the peritoneal cavity becomes turbid with increasing amounts of protein, white blood cells, cellular debris, and blood. The immediate response of the intestinal tract is hypermotility, soon followed by paralytic ileus with an accumulation of air and fluid in the bowel. Clinical manifestations. Symptoms depend on the location and extent of the inflammation. The early clinical manifestations of peritonitis frequently are the symptoms of the disorder causing the condition. At first, a diffuse type of pain is felt. The pain tends to become constant, localized, and more intense near the site of the inflammation. Movement usually aggravates it. The affected area of the abdomen becomes extremely tender and distended, and the muscle becomes rigid. Rebound tenderness and paralytic ileus may be present. Usually, nausea and vomiting occur, and peristalsis is diminished. The temperature and pulse rate increase, and there is almost always an elevation of the leukocyte count. Assessment and diagnostic findings. The leukocyte count is elevated, the hemoglobin and the hematocrit levels may be low if blood loss has occurred. Serum electrolyte studies may reveal altered levels of potassium, sodium, and chloride. An abdominal X-ray is obtained, and findings may show air and fluid levels as well as distended bowel loops. A CT scan of the abdomen may show abscess formation. Peritoneal aspiration and culture and sensitivity studies of the aspirated fluid may reveal infection and identify the causative organisms. Complications. Frequently, the inflammation is not localized and the whole abdominal cavity becomes involved in a generalized sepsis. Sepsis is the major cause of death from peritonitis. Shock may result from septicemia or hypovolemia. The inflammatory process may cause intestinal obstruction, primarily from the development of bowel adhesions. The two most common postoperative complications are wound evisceration and abscess formation. Any suggestion from the patient that an area of the abdomen is tender or painful or feels as if something just give away must be reported. The sudden occurrence of serosanguinous wound drainage strongly suggests wound adhesions. Medical management. Fluid, colloid, and electrolyte replacement is the major focus of medical management. The administration of several liters of an isotonic solution is prescribed. Hypovolemia occurs because massive amounts of fluid and electrolytes move from the intestinal lumen into the peritoneal cavity and deplete the fluid in the vascular space. Analgesics are prescribed for pain. Antiemetics are administered as prescribed for nausea and vomiting. Intestinal intubation and suction assist in relieving abdominal distension and in promoting intestinal function. Fluid in the abdominal cavity can cause pressure that restricts expansion of the lungs and causes respiratory distress. Oxygen therapy by nasal cannula or mask can promote adequate oxygenation, but airway intubation and ventilatory assistance occasionally are required. Massive antibiotic therapy is usually initiated early in the treatment of peritonitis. Large doses of the broad spectrum antibiotic are administered intravenously until the specific organism causing the infection is identified and appropriate antibiotic therapy can be initiated. Surgical objectives include removing the infected material and correcting the cause. Surgical treatment is directed toward excision, that is appendix resection with or without anastomosis, that is intestine repair in case of perforation, and drainage in case of abscess. With extensive sepsis, a fecal diversion may need to be created. Thank you.